my voice? Is it clear now?
Yes, voice is clear.
Okay.
You can start now.
Hello, my name is Dr. Khan. I'm one of the referring clinic today. May I confirm you are Mrs. Rahila, 60 years of age?
Yes, doctor.
Today we are here to discuss regarding your health condition and we will examine you also. Is it okay for you?
Yes, doctor.
From your notes, I gather that you have history of joint pains, stiffness, and backache. Is it true?
Yes, doctor, you're right.
Any other complaint you have?
No, doctor.
Any past health condition you have that I should be aware of?
Yes, doctor. I have high blood pressure. For that, I'm taking medicine, but it is well controlled.
Okay, I can see this must be difficult for you and we will try our best to sort it out and guide you accordingly. Okay.
Thank you, doctor.
Can you explain a bit more about your symptoms?
Yes, doctor. I was all right, and 3 months before, all of a sudden, I started having aches in my joints and my back and throughout my body. I was thinking
Okay.
it's because of my heavy work, because I'm an accountant, but it doesn't seem that it's not getting better. So I have tried some medicine from the GP, but it didn't help me a lot. So I came here today
Okay.
to seek help from you.
Okay. And was that these symptoms developed together, joint pain, stiffness, and backache, or they were separate?
Initially, there was a stiffness in my joints. Then it's starting aching after 1 or 2 days, and
Okay.
since then, it's the progressive.
Uh, okay. Where exactly you have joint pains? Which joints?
In my hands,
Okay. Is it in the full hands or any specific joint you are having this pain?
my both hand joints and my all wrists also, and sometime I'm feeling that my having pain in my knee joints also.
Uh, okay. Okay, fine. What about the backache? Where exactly you are having the backache? Upper back, middle back, or lower back?
In the lower back, doctor.
Okay, lower back. What about the stiffness? Uh, is it less than 1 hour or more than 1 hour?
It's stiffness, doctor, more than 30 minutes. Sometimes it's delayed to 40 minutes, sometimes 1 hour, you know.
Okay, okay, okay. What is the quality of joint pains? Like dull aching pain, sharp stabbing pain,
It's a dull, doctor.
dull pain. And what is the intensity between 0 to 10? 0 is the mildest and 10 is the strongest pain of your life.
You can say it's 5 to 6, doctor.
Okay. Does it goes to any other sides, like it going to the legs or in the hands going to the shoulders?
Yes, sometimes I feel that the pain from back is traveling towards my back of my thighs.
Okay, back of the thigh.
Yeah.
Okay. Anything which aggravate these symptoms, especially joint pain?
Physical activity, and especially when I'm sleeping, doctor, it's killing me. Early morning when I'm getting up from my sleep, I'm
Hmm.
unable to move my whole body. I'm stiff like a jelly.
Okay. So does it improves with activity?
Yes, by the passage of time, what I'm moving my hand, my body, and I'm busy in my work, it getting better.
Okay. Do you have any high body temperature?
Uh, Not, I don't know, doctor, actually. I didn't notice.
Okay. Any history of headache you have?
No,
Okay. Any lumps and bumps in the body?
no lumps and bumps.
Any rash in any part of the body?
No, I didn't notice any rash.
Okay. Any change in appetite?
Yes, my appetite is getting, decreased as not as much as usual.
Okay. Any change in weight you have noticed?
No, I didn't notice any weight change.
Okay. Any problem in the sleep?
Yes, sleep. Yeah, doctor, you're absolutely right. You're a very good doctor. I'm unable to sleep nowadays because of this problem. Wake up at night and sitting hours and hours to relieve my symptoms.
Okay. Anyone notice you are snoring at night?
No.
Okay. How's your mood nowadays?
Mood, I am feeling myself depressed, doctor.
Okay. Do you think life is beautiful?
Life is beautiful, but my disease is very impacting very bad on my life.
Uh, okay. Okay, fine. Okay. Do you have any history of rash?
No, doctor, I told you that I don't have any rash.
Okay. Okay. Thank you. Okay. Are you taking any balanced diet?
Yes, doctor.
Okay. Any history of injury to the hand or the back?
No,
Okay. Uh, okay, fine. Any change in the bowel works?
no, doctor.
Uh,
Sorry,
any pain while combing your hairs?
I am unable to comb, doctor, nowadays. It's seems very difficult task for me.
Okay. You feel pain in the scalp while combing?
No,
Okay. Okay, fine. Do you have any past medical surgical procedure?
no,
Okay. Any known allergy to any food and medicine or any other thing?
no, doctor.
What medication you are taking apart from amlodipine?
No medicine is such as said ibuprofen, and sometime I'm, applying some local applicants like Voltral gel.
Okay. Any medication recently stopped?
No,
Any diagnosed condition you have in family?
no, doctor.
Uh, okay. May I ask some personal question? Is it okay?
Yes, doctor, sure.
Do you have long-standing partner?
Yes, doctor.
And how many kids you have?
I have three kids.
Okay. And when was the last delivery?
It's about 10 years now.
Okay. And how's your periods nowadays?
Kids are fine, doctor.
Okay. Okay, fine. May I examine you now?
Yes, doctor, you can examine me. What do you want to examine, doctor?
Okay, I will start from the hands. And first, I will ask the patient to put the hand on the pillow. I will check
Okay.
any visible deformities are present
No
or not.
deformity.
Okay. Then I will check the median nerve. I will check the opposition, and then I will check the abduction of the thumb also. I will check prayer sign, reverse prayer sign, and I will ask the
Prayer sign.
patient to.
Prayer sign. Patient can do the prayer sign, and patient can do the reverse prayer sign also.
Okay. Then we'll ask the patient to pick up the coin or button or unbutton.
Patient can button another button.
Okay. Uh, then I would like to do the tunnel test of this patient also. Is this positive or not?
Negative.
Okay. And I will check any nodule is
How
present
you
near
will
the L.
a tinal test? How you will do tinal test? What you will
I will
do?
tap the wrist at the ulnar border to check any
Okay.
electric jerk or pain is coming or not.
And you will ask the patient, right?
I will take permission from examiner as well patient.
No, no, no. You will ask the patient if she
Ask
feel
the
any
patient.
numbness or tingling.
Any
Okay.
electric jerk or pain, please let me know.
Okay. Okay. Fine.
Okay. Then I will check the pulse and the blood pressure of this patient.
BP is normal. Pulse is normal.
I will check proximal myopathy. Is it present?
A patient is unable to move her both arms.
What does it mean that cannot move shoulder?
No, no. Patient is unable to raise her hand above the shoulder.
Okay. Okay. Any thickening of the skin present below elbow or above elbow?
No thickening.
I will see the eyes for pallid and jaundice, mouth for any oral rash.
No pallor, no jaundice.
Okay. And then I will check the back. I will expose the back and then I will check any
What
visible
do you want?
deformities, karma.
Patient is unable to expose her limb. What do you want to see in the back?
I will check any visible deformities, scar mark, or
No deformity, no scar mark.
okay. And then I would like to do the tenderness. Is tenderness present lower back or not?
There is a positive tenderness.
Uh, okay, tenderness is present. Okay, and then I will ask the patient, can he bend his back or not?
What is the name of this test, this maneuver?
For bending the back,
Yeah.
that is a modified Schober test we do.
Okay.
And
You want to do the modified Schober test? You can do.
no, I just want to see the mobility if it is present or not.
Patient is unable to move her spine. She is unable to bend forward.
Okay, and any restriction in we will ask the patient to move right or left or up and down.
There are restricted movements.
Okay, and then I will see the eyes. Any redness of eyes is present.
You already have checked the eyes. Eyes, no
Okay,
redness.
okay. And then I will auscultate the precordium. Any murmurs, especially aortic regurgitation, loud P2, palpable P2, raised JVP.
No raised JVP, though no AR and no palpable P2.
Okay, I will check tenderness in the ankle, Achilles tendon, if it is present or not.
No tenderness.
Okay, and I will see a posture of the patient. Is there any kyphosis or question mark posture is present?
There is a no question mark and there is no kyphosis.
Uh, okay, so
Would you like to
do
check
you
the
smoke?
wall to occiput ratio?
Yes, I will check wall to occiput ratio. I will check chest expansion and modified Schober test also.
Modified, you are already done. Patient unable to perform this test.
Wall
And chest,
occiput distance I will check.
okay, it's normal.
Uh, okay, okay. Do you smoke?
No, doctor.
Do you take alcohol?
Yes, occasionally.
Okay. What's your job?
I'm a accountant, doctor. I told you.
Okay. Does this condition affect your job and daily life?
Very badly, doctor. I'm missing my job nowadays for last, I think, more
Okay.
than 20 days now. I'm sitting at home.
Do you need any help from us? We are here to help you out.
Of course, doctor. How can you help me?
We will involve our social care worker and occupational physician. They will try to help you in this regard. Okay.
Social health worker and
Occupational health physician.
health physician. Okay.
Okay. And do
Okay.
you drive?
Yes, doctor. I do drive.
Any problem while driving?
Yes, I'm not unable to move my body. Yes, doctor. I'm not able to drive.
Okay. Well, I will like to advise you that you should stop driving and inform DVLA regarding your condition. They will
Minutes left.
guide you further in this regard. Okay.
Okay,
Any
doctor.
history of recent traveling?
No,
Uh, okay. Do you have any change in waterworks?
no.
Uh, okay. May I ask, do you have any concern?
Yes, doctor. Can you tell me, doctor, what's going on with me?
Well, from the history, it looks like that you are suffering from a medical condition called osteoarthritis, and due to which you have a problem in the hand joint pains and back pain and the restriction of movement also. There is
Hmm?
other possibility of medical condition called ankylosing spondylitis, but I could not find on the examination. I will do further investigations to confirm my
Okay,
diagnosis. Okay.
okay.
Any other concern you have?
Yes, doctor. Will I get better?
Well, with the proper follow with a team of specialists and medication and exercise, this condition can be better. Any other concern you have?
Maybe, doctor, I have a cancer.
From your history, it looks unlikely that it can be cancer, but still we will do further investigations to confirm our diagnosis. Any other concern you have?
Yes, doctor. I'm worried about that. Is it a treatable condition or not?
I appreciate your concern. Well, this condition can be controlled, and but unfortunately cannot be completely cured. So with the follow-up with the team of specialists, this condition can be controlled, and you will feel better. Any other concern you have?
No, doctor. Thank you.
Okay, so we will involve a team of specialists, including the joint doctor, physiotherapist, specialist nurse. They will make a proper plan for
I'm
you.
up.
And thank you for your time.
Okay. Summarize up your case, Dr. Sarfraz, and present up your case. If you are ready, you can present now.
Okay, give me can 1 minute. Can I take?
Oh, yes, yes, yes. You have 60 seconds. Time up.
Okay. This patient present. Should I explain the history also, or only finding?
Present your case as you are in real
Okay.
exam.
This patient, Mrs. Rahila, 60 years of age, presented with a joint pain, stiffness, and backache since 3 months. And it started gradually. First, there was a stiffness, and the patient developed the joint pain and the backache also. And there was a stiffness was present more than 30 minutes. It was varying between 30 minutes to 1 hour, and sometimes more than 1 hour also, but majority more than 30 minutes. And
Mhm,
the character was a dull ache, 5 to 6 out of 10. And there was a sometimes the back pain was radiating to the back of the thigh also. And this pains increases on the rest and relieves on activity. And there is a decreased appetite, and there is a sleep disturbance present. Patient is feeling depression, and
mhm,
uh, uh, patient was doing driving also, which I stopped. And on examination, patient was having the proximal myopathy, unable to raise the shoulders uh, above the shoulder, and
mhm,
there was a tender back, and there is a restriction of the neck also. And uh, I did the modified Schober test, but there was no significant finding, and restriction of neck was present. The wall occiput test was negative, and so based on these history and examination,
mhm.
should I explain the differential?
Yes. What's your differential diagnosis in this case?
I have three differential. I will keep the osteoarthritis due to the old age, 60 years, postmenopausal woman. And
Mhm,
I will keep the ankylosing spondylitis also. There's a restriction of the neck is present, although I could not
mhm,
find the Wall-Ossiput test, but I will keep that also. Number three,
mhm,
I will keep the functional cause also due to depression. It can be
mhm.
fibromyalgia also. So these are my differential.
Okay. So, would you consider any other diagnosis? What do you think,
There was
Doctor
a
Sarfraz? Is there any
Mhm,
morning stiffness in osteoarthritis which you are considering at the top of your differential diagnosis?
mhm, mhm.
Is there any morning stiffness? It's a bilateral. It's an involvement of the lower back area also.
Okay.
Do you think?
Uh, with the morning stiffness, I have like rheumatoid arthritis, but I could not find any deformity in the hand. And
Okay.
but I will keep the differential. And there was a giant cell arthritis also, where we find these symptoms, and but there was no headache, and they are becoming low down the order.
So, do you want to say that joint cell arthritis is presented with the morning stiffness, right?
It can present with the morning stiffness, but it could be less than 1 hour.
Okay. So, do you want to do in this case a fundoscopy?
Uh, I will like to do the fundoscopy, and I will check any papilledema or optic atrophy is present.
Okay. So, is there anything else you want to add in this differential diagnosis?
Uh, no, no.
Okay. So, how you will investigate this case?
First, I will the complete blood count to check the anemia, inflammatory markers, ESS, CRP, and
Hmm.
then I will do the HLA-B27 testing for ankylosing spondylitis. Also, I will do the anti-CCP antibodies for rheumatoid arthritis, and
Hmm.
then I will do the X-ray of the involved joints for any deformity, and
Hmm.
then I will do the MRI of the back also if it is required.
Okay. So, what you're expecting in CBC in this case?
Hello,
What you are
sorry.
expecting in this case? In what you want to see in the CBC?
CBC, I will check only the uh, uh, anemia of chronic disease.
Okay. Okay. So, how you will manage this case?
We will make a team of specialists, including the physiotherapist, specialist nurse, and rheumatologist, and a dietitian also. They will make a proper plan. And first, they will non-pharmacologically, we will do the patient education, psychosocial support. We will do the physiotherapy, and
Hmm.
also the dietary advice. If the diet should be balanced one, and pharmacologically, we will give the painkillers and sets, and then we will give steroids if required.
Okay. Okay. Is there anything else you want to add?
If patient not getting better with steroid, we can add the immunosuppressive medication like methotrexate, and then uh, biological agents also if not controlling with this medication.
Okay. Okay, Dr. Sarfraz. So, very good, Dr. Sarfraz. Wonderful performance. You have done a good job, but there are few things need to add in your whole case.
Mhm.
So, what do you think? What was the case? Let's talk about now
Uh,
discussion.
I wanted to see the picture actually, to be honest, and but since it was a 30 minutes of uh, uh, stiffness, so it could not be rheumatoid arthritis. So
Hmm.
I will keep the giant cell arthritis and uh, osteoarthritis, polymyalgia rheumatica also, and uh, ankylosing spondylitis and the functional possible.
Okay, so very well done. So, actually, this case was a polymyalgia rheumatica, and this
Mhm,
case was came in last died at Lahore Center. So this was
mhm,
the history of a 63 years old lady, and she was complaining of joint pain, stiffness, and you know, uh, one is a backache also for last 3 months. And this was the case. So let's start your you know uh, performance from the beginning. So your
mhm,
introduction was very impressive. So you mentioned that my name is Dr. Sarfraz. I'm one of the doctor today here. Am I talking with Mr. Rahila, 63 years age? Very well done. You set an agenda. Very well done. So we are here to discuss with you about your health condition. Is that okay with you? Then you said that I can see from your notes that you are having these conditions. Is that right? Is that well done? Then you bring up sympathy and empathy. Very well done. And you also ask about the past medical history and past drug history. That's wonderful. So coming to the Lokira or Odipara, you did very well. But there was few things were missing in your ODPARA or Lakira, whatever mnemonic you are using. So
Mhm.
onset, duration, progression, aggravating, and relieving factor, that was perfect. But you need to establish what kind of arthritis or joint pains is that. So pattern was missing there. So you missed that pattern. What is the pattern of this arthritis? That is very important actually. If you don't know the pattern, so then coming to the next aggravating and relieving factor, then coming to the association. So I was expecting that you will start from the rheumatological questions first, and then you will come to the general questions, and meanwhile you will rule out other differential diagnosis if you are keeping in your mind. For example, what you should ask when you finish your OD-para associated local questions, local tenderness, swelling, skin rash, and any crepitus sounds like. Then coming to the rheumatological, once you are dealing with the rheumatological disorders, so you need to ask the questions starting from the Raynaud's fingertips, then nail changes, then joint swelling, then coming to the elbow, coming to the wrist, then thickening of the skin, then the elbows, then the up proximal myopathy, then the neck, thyroid, lump and bumps, eyes redness, and any dryness, and any grittiness, mouth ulcers, alopecia, facial rash. Especially in this age group, you need to ask about the heliotrope rash or facial rash, this photosensitive rash. Then ask about the hair fall. Then coming to the, flow the urine or any change in color of urine. These are the rheumatological questions you need to ask in every case once you are dealing with the joints. Okay, that was missing in your case. Actually, you started from the headache, lumps and bumps, then rash, then you went to the general questions, weight changes, sleep, snoring, injury, bowel, proximal myopathy. So pattern was missing. Otherwise, it's a good examination scheme. Coming to the examination scheme, Dr. Sarfraz, let me share with you some few slides, which I have tried my best when we are dealing with the rheumatological joint pains. So let's see here. So we have a monoarthritis, we have a polyarthritis and symmetrical, and the fourth category which we are missing usually as a student, as a candidates, that's a muscle problems we are always missing in our histories. So mono means Scott means septic, crystal induced osteoarthritis and trauma. Oligo or polyarthritis less than 5 joint or more than 5 joint, that's crop for crystal induced, R for reactive, O for osteoarthritis, P for psoriatic arthritis. Then coming to the symmetrical, RA, SLE, and viral. So the fourth category is a muscle problem. DM, dermatomyositis, polymyositis, polymyalgia rheumatica, and fibromyalgia. If the age is more than 50 years, if the patient is having stiffness, you should think about once step, take a step back and think about the fibromyalgia. Okay. Sorry, PMR. If the age is more than 50, you should think about the PMR first at the first differential diagnosis, then move to the other differential diagnosis. If the similar patient is less than 50-year age, then fibromyalgia you should be a top differential. So
Mhm.
next, coming to the after ODPARA, this associated local questions, stiffness, skin rash, swelling, or capitis, and examination uh, scheme was missing here. So there are other slides. Sorry. So Raynaud deformity, thinning of the skin, proximal myopathy, lymph node, eyes, facial rash, alopecia, oral ulcer, and okay, I will explain it again. So oral ulcers, range of movement, activity, and passive and active. Then the complications. So your examination was not as I was expecting. If you are feeling, if your differential diagnosis, for example, ankylosing spondylitis. So what is the scheme of ankylosing spondylitis examination? Uh, you can start it from the standing position or starting position. Both position are good, but if you are dealing with the ankylosing spondylitis, my suggestion will be to start from the standing position and ask the examiner. So I want to do the Shoba test first. I want to check this tenderness. The patient examiner is telling you this, there is a tenderness is positive. Then, if you feel the patient is unable to bend, you can skip this test. Then wall to occiput ratio and change and check the range of movements in all directions, starting from the neck flexion extension and the lateral flexions and hip movements also, forward flexion. back flexion, okay, then the lateral flexion. These are the most important steps you need to do. Okay, then ask the patient to sit down, starting from the hands. Okay, you can check, rule out the differential diagnosis, RA, SLE, dermatomyositis, polymyositis, fibromyalgia, and polymyalgia rheumatica. Once I gave you that patient is unable to raise her hands above the shoulder, you need to ask about, do you have any stiffness in the joints or in the shoulders? Definitely, I gave you the clue. Yes, I have. You missed a few questions that were very important in this case. Then coming to the investigation plan, investigation was good. So how you will investigate a case of polymyalgia rheumatica, Dr. Sarfraz?
We will do the basic complete blood count in anemia chronic disease, inflammatory markers, ESR, CRP,
Mm-hmm.
and
Mm-hmm.
X-ray and MRI of the joint, involved joint, the shoulder joint.
Okay. So ESR or CRP, which is more sensitive?
Uh,
CRP is more sensitive,
CRP.
okay, in case of PMR. So you can do a CBC for anemia. Normostatic anemia must be there, not a anemia of chronic disease. ESR, CRP. CRP is a more sensitive. Then rule out the other differential diagnosis in this case. The top differential in this case, let me talk to you first. Top differential in this case is late onset of rheumatoid arthritis. If you are putting the differential diagnosis of PMR at the first instance in your case, PMR, then late onset rheumatoid arthritis, seronegative spondyloarthropathies, and this vasculitis, especially this uh, what is giant cell arthritis, okay, and any other viral disease you can put in this case. So you need to do the workup of these, at least these conditions. So RA, anti-CCP must be negative. Then the muscle enzyme, muscles are affected there, CK, LDH. And also you can do for the specific PMR use, if you want to rule out, if you rule in the PMR, then ultrasonography, CT, MRI, and PET scan are very sensitive tests to see the any pathology in the muscles. So can you tell me where is the exactly pathophysiology? What is the pathology in PMR? Muscles are normal
Uh,
there, right?
it is a vasculitis.
It's not a vasculitis even.
Okay.
Okay,
Mm,
it's not a
mm.
vasculitis. So it's basically proximal articular and periarticular structures, bursa and tendons, they are got affected, especially in the upper limb, the deltoid, sorry, biceps and subdeltoid bursitis are involved. That's why the patient is having early morning stiffness, and the cervical introitious bursitis also there. In the lower limb, hamstring tendonitis, okay, and hip synovitis. These are the most common presentation and most common pathologies occurring in the PMR. The exact reason of the PMR is unknown, but there are few possibilities, a few HLA association, HLA-DR4, and also interleukin 6 is increased in these cases. So you can investigate these by the labs. The most common presentation is patient is unable to move her or his hand above the 90 degree of abduction. Okay, and puffy edematous hand syndrome may occur. I can show a picture of this case, which might be helpful for candidates who are going to appear in exams. So this is the distribution of actually left on the left side. You can see a picture, red shaded areas. These are the picture. Basically, patient is suffering from the PMR. The middle picture, you can see a patient is unable to raise the hand above the 90 degree after taking a 1 week of steroids. Her movements of the hands improve, and he's up, raising his hand above the shoulder. And on the left side, on the right side, there is a hand. So this is a hand syndrome which can occur in PMR. So if you are having case, if you will face this case in exam, don't miss this diagnosis either in the direct or indirect way. Indirect way mean you can give the differential diagnosis of PMR with the rheumatoid arthritis and ankylosing spondylitis. Treatment, you have mentioned very well, NSAIDs. We can give in this patient steroids, okay, low dose steroids. And if patient is not improving, then we can go for the methotrexate immunomodulator, sometimes TNF inhibitors and interleukin 6 inhibitor, tocilizumab, can be used. And there is new drugs which are well approved. There is sarilumab. This is it's interleukin 6 inhibitors. So these can be used in this case. So this is what about the today's case. Is there any question, Dr. Sarfraz, you are having at the moment?
No, no. What
So
about the why there was a next restriction of movement?
next restriction, because cervical area is also involved. Cervical
Sorry, can you
introitious
repeat?
cervical introitious
Okay,
bursitis
okay,
is
okay,
involvement. That's why the patient is unable to move neck in all plane. Actually, the patient can give you the complaint of whole body stiffness. Okay,
okay.
legs, arms, spine, thoracic region, chest region,
Mhm.
lumbar region. So if there you are dealing with this stiffness in old age, I again repeat my words, step back for 1 second and think about the PMR, that maybe you are dealing with the PMR in this case, if you are facing this case in exam.
Okay,
Okay.
okay.
So is there any question from anyone? Dr. Sarfraz, I will add one more thing. Maybe I am going to repeat again. Once you are dealing with any joint pain
Okay.
in your exam, okay, please screen all 3, 10, 12 questions which are related to the rheumatological conditions. Before moving further, uh, just a minute. I have one slide. I have prepared it today, but why missing? Okay, I will share in the group. Okay,
Okay.
just a minute. Something else I have here. Here is a format of any long clinical consultation when you are dealing in exam. Okay, so introduction, agenda, sympathy, empathy. Okay, past and medical and drug history. Please do ask in the beginning, so you will not lose your time, you will not waste your time. Then come to the odipara associated local symptoms. Whenever the joint pain is involved, there are 4S. Okay, 4S is no uh, this is stiffness, okay, swelling, and skin rash. And fourth, I have missed in my mind. So coming to the associated general, so you will rule out differential diagnosis here. And coming to the next part in your history must be to look for the complications, if you are keeping in your mind any case in the clinical sessions, in clinical examination. Their main target is not straightforward disease. They are always giving you some task to search for a complication of that particular symptom. So you need to search, like Dr. Sarfraz was doing, that he was auscultating the heart for AR and auscultating the lungs for the apical fibrosis, achilles tendinitis. So these are the complications. Then WAFS stand for general questions: weight change, anorexia, fever, fatigue, itching, rash, racing in the heart, sleep, snore, and sweating, and impact on job and social life. So these are the very important points, and driving is missing here. Then the personal history and examination. So these are the steps you need to follow in each and every case. If you are running out the time, at least you have touched each and every category. Dr. Sarfraz did very well. I was keeping the candidate must ask about the driving. These were my hidden agendas. Must ask about the daily livings, comorbid conditions, and must rule out the GCA, giant cell arteritis. He did very well, and concern was what is going on with me. So he was unable to provide the whole information at that time. But why? Because he was keeping his differential diagnosis osteoarthritis at the top. And why will I get better? He said, Yes. So I think he should say, he must say here to answer this concern must be like this. I highly appreciate your concern, Miss Rahila. It's very early to say you will get better or not. Uh, we are going to run some blood tests and scan your body once the result will be available, and we will sit together and will guide you further according to the results. So, is it a cancer? He said, based on your history and examination, it's unlikely. Well done. It's unlikely, but we need to investigate. But a lot of PMR cases are associated with the cancer, also written in the books. Is it a treatable condition? He respond very well to this concern. So it's very early to say it's a treatable not, but it can be controlled rather than it's not a curable disease. So this is what I had about this case. If any concern, any question from anyone, we are here to discuss, and we will be very happy if there is any question from anyone. If no question, then I'm going to end this meeting.